Okay, so top of the hour to you all. My name is Onowore Victor. I am a neurology applicant and I will be doing the Change Change Comprehensive Review in Clinical Neurology. We'll be taking question 34 to 36 this day and let's get started. Question 34, we have a 58-year-old woman with a history of hypertension, diabetes, and hyperlipidemia who presents to the emergency department for left facial droop. She woke up this morning and noticed unilateral facial paralysis on the left, which was not present the night before. Okay, so she also reports hyperkinesis of the left ear and says that food tastes different. There have been no other new symptom over the past year of any kind. On examination, she noticed left facial drop and inability to close the left eye. She is unable to wrinkle the left side of her forehead. What is the most likely diagnosis? Now, this is screaming cranial nerve number 7 lesion, facial nerve lesion, and the since the entire left face is taken, both the upper and the lower part of the face is looking like a lower motor neuron lesion of the seventh cranial nerve, and she had no prior illness. This is looking like someone who has Bell's palsy. So let's do a little discussion about Bell palsy. So the first thing we should note is that whenever you have a patient who you are suspecting for Bell's palsy, there is really no need for you to do any form of testing. Yeah, and you should just initiate this patient on steroids. Now, Bell's palsy is what we use to describe an acute peripheral facial nerve palsy of unknown cause. Now, it's frequently seen in the third trimester of pregnancy or in the first postpartum week, and it is also seen in patients who have diabetes. However, you can actually see it in any kind of patient. Now, there has been possibility that this is caused by herpes simplex mediated viral inflammatory mechanism, but there are other viruses that have been associated with Bell's palsy from VZV, varicella zoster virus, to which causes Ramsay Hunt syndrome. So other etiologies that are still controversial. Now, for people who have diabetes, the proposed mechanism is that there is some form of ischemia to the facial nerve. Patients with Bell's palsy typically present with relatively abrupt onset of unilateral facial palsy or paralysis, and often you have difficulty in closing the eyes. You have drooping of the eyebrow, the mouth droops, and there's a loss of the nasolabial fold. There's a loss of taste sensation in the anterior third of the tongue, which are basically the distribution of the facial nerve. You have decreased tearing, and then you have hyperacusis due to loss of inhibition of the stapedius that helps to dampen sound. So, patients may also complain of discomfort behind or around the ear prior to onset of the symptoms, and there may actually be a history of a recent URTI. Now, it's actually important to be able to differentiate between a peripheral and a central lesion, that is an upper and a lower motor neuron lesion. Whenever you have sparing of the forehead, that means that it's a central lesion. This is due to bilateral cortical supply of the facial nerve subnuclei, which innervates the forehead, as opposed to unilateral cortical supply to the facial subnuclei that innervates the lower face below the eye. Now, you should note that a lesion to the facial nerve nucleus itself in the pons can actually lead to complete facial paralysis of both upper and lower face. And Bell's palsy should classically involve only the facial nerve, although additional cranial nerve involvement has been frequently reported, including trigeminal, oropharyngeal, and hypoglossal nerves. Now, a diagnostic study is not necessary in all patients with Bell's palsy, like we mentioned before, and those with a typical history and examination that are consistent with Bell's palsy just need to be on corticosteroid therapy. The only reason why you should consider imaging is if there is slow progression between beyond 3 weeks, or if the physical signs are atypical, or you are seeing other cranial nerve involvement and you're not so sure. Also, if there are no improvement after about 6 months, then you may pursue an imaging, and the best imaging is actually an MRI with and without contrast. I need to make clear emphasis on the fact that a pontine stroke can actually cause symptoms that look like Bell's palsy, but usually they have other structural involvement. So, classical example is that sometimes you can actually have a pontine stroke that may not just affect the facial nerve nuclei, but may also affect the abducent nerve nuclei. At the same time, the contralateral corticospinal tract. And when you have the facial nerve infarct alongside with hemiparesis of the opposite side, we call that Millard Gobler syndrome. Now, if you now have ipsilateral impairment in eye abduction alongside with uh, facial nerve palsy, that means that you actually have an infarct to both cranial number 7 and 6, the abducent nerve, and we call that the Fovley syndrome. Now, these additional focal symptoms should actually prompt an investigation for a pontine infarct. Now, this patient did not have a history of symptoms consistent with Lyme's disease or multiple sclerosis. Multiple sclerosis will be highly suspected in a young patient who has bilateral Bell's palsy, although Lyme disease and sarcoidosis will actually be differential. So let's go down to treatment. Treatment of this of Bell's palsy is a little bit controversial because there is controversy between using steroids or using steroids and antivirals. Now, if you have a patient who has knee onset Bell's palsy, steroids can be very effective, and it should be offered to increase the probability of recovery of the facial nerve function. Now, the addition of antiviral agents does not significantly increase the probability of facial nerve function recovery, but a modest benefit really cannot be excluded. Now, due to the possibility of this modest benefit, patients might be offered antivirals in addition to corticosteroids, particularly in more severe cases of facial nerve palsy or those with possible varicella zoster infection. We call that zoster sin herpes. Now, it's good to give artificial tears to patients, and it should also wear eye patches when they want to sleep for eye protection when needed. Nerve stimulation and surgical decompression are not routinely recommended on the basis of current evidence. The prognosis actually depends on the severity of the lesion, and generally, clinically incomplete lesions tend to recover better than a complete lesion. In addition, the prognosis is favorable if some recovery is seen within the first 21 days of symptoms onset. So now that we've established that the diagnosis is actually Bell's palsy, let us go to the other question. So question 35, what is the most appropriate diagnostic and or management strategy at this time? So brain MRI and MRE of the circle of Willis that will be first, brain CT that will be first, lumbar that will be first, MRI that will be first, observation that is true. Now, what initial treatment do you recommend at this time for the patient? Prednisolone, obviously, that is the answer. So I think we should just do 37 and 38, so that in our next episode we start with 39. Yeah, good. So let's do 37. Which of the following cranial nerves does not have a synapse in the thalamus before terminating in the cortex? Now, this is actually a question of do you know it or do you not know it? And funny enough, this is actually a very simple question. Now, the answer to this is the olfactory nerve. Now, it's important to note that the olfactory nerve is the only nerve that does not have a synapse in the thalamus prior to traveling to the cortex and afferents from all sensory modalities except for the olfactory nerve have a synapse in the thalamus prior to terminating the cortex. Now, from the olfactory bulb, we have secondary neurons that project directly to the olfactory cortex, and they have direct connections to the limbic area. The limbic area actually plays a very huge role in memory formation, and this explains why some smells provoke specific emotions and memories. The olfactory cortex has connections with autonomic and visceral centers, including the thalamus, and the amygdala. This may explain why some smells can cause changes in the gut motility, can cause nausea, and can cause vomiting. So for this question, all you just need to do is to look out for the option that says olfactory nerve, which is option C, and then pick it up. So 38, we have a 43-year-old man with a history of right-sided Bell's palsy the prior year who made a good recovery. He comes to you complaining of excessive tearing in the right eye, mainly when he's eating. What do you attribute this to? Now, this is the classical crocodile tears. Okay, so let's talk about crocodile. This results due to a misdirection of regenerating facial nerve, which originally supplied the submandibular and the sublingual glands. Now, this facial nerve now supplies the lacrimal gland through the greater petrosal nerve, and this anomalous supply causes abnormal unilateral lacrimation when eating. Now, sometimes you may actually have renervation or misdirection of the nerves that supplies the labial muscles that enables you to smile, and then these nerves then goes on to supply the orbicularis oculi. So when the patient is smiling, the nerve will also cause the orbicularis oculi to close, and this phenomenon is called synkinesis. And the reverse can also occur when the patient blinks. There is twitching of the mouth, yeah, and this is due to, like I said, um, renervation that went wrong. The first option says early recurrence of Bell's palsy, that's false. B is absence of normal facial nerve inhibition of overactivity due to prior damage from Bell's palsy, that's false. C is renervation of the lacrimal gland by the glossopharyngeal nerve, that's false. Not glossopharyngeal nerve, by the greater petrosal nerve. D is renervation of the lacrimal gland by the trigeminal nerve, that's false. E is regeneration of the lacrimal gland by misdirected facial nerve action, that's true. Option C, E.